How much pressure is your patient's heart having to overcome just to get the blood out of the heart? The answer to that question is your afterload. My name is Leah. I've been a CVSU nurse for 18 years, and today we're going to continue our hemodynamics series. We've been talking about the equation cardiac output is equal to heart rate times stroke volume. And we've gone through stroke volume and said that it is made up of preload, afterload, and contractility. In the last video, we talked about preload, and today we're going to talk about afterload. So, as we talk about afterload, we have to really just think that the heart wants to push the blood out. That's what it's doing. The ventricle is contracting and blood is pushing out. And it pushes out into the aorta. So, when we talk about what's going to be causing pressure, we're thinking like this is what we call hypertension. Whenever it's too high, the pressure is too high to get it out. But we can actually look at something that gives even a smaller detailed look inside the heart, and that is SVR. SVR is the systemic vascular resistance, and that is the pressure that the heart has to overcome to squish blood out into the aorta, systemic vascular resistance. That's on the left side of the heart. On the right side of the heart, there's something called PVR. You can get the pulmonary vascular resistance, and it tells us the same thing. How much resistance does the right side of the heart have to overcome to push that blood? So, as you can imagine, just like every other thing we've talked about, we don't want it to be too high, but we also don't want it to be too low. Both things could be bad. We'll mostly talk today about the left side of the heart because that's really what we see the most. And in subsequent videos, I'll try to make one that talks about the right side of the heart and the PVR a little more. So when we talk about SVR, the normal range for our patients is 800 to 1200. Some facilities like to use the SVRI and it's indexed down a little bit more to body mass and size of the patient. SVR is still being commonly used though, and at my facility, we use SVR. So SVR at 800 to 1200, if your number is less than 800, then that means that that patient is still pretty dilated. Those vessels, the aorta and all the other vessels are probably really dilated still. And if your SVR is higher than 1200, that means it's clamped down. It's harder for blood to get out. So if we have a patient that has a low SVR, that's actually not uncommon after surgery. We could see that whenever the patient has been on the bypass machine as their blood has been going through these plastics and it causes a systemic inflammatory response to that plastic of the machine as the patient's on bypass. And we also see it for a little bit because of some of the anesthetic agents that were used. So it's super common to have a patient that just came out after bypass surgery and see a low SVR. However, if your patient has a low SVR, let's say that normal is 800 to 1200 and your patient's is 700, but your cardiac output is perfectly normal, you're not going to intervene. SVR is just a tool for you to look at and say, hey, how can I optimize this to make the patient get the right amount of blood flow out to their body? If the patient's already doing that and having themselves compensate in other ways, we don't have to go fix the SVR just if the cardiac output and everything else is normal and looks good. On the other end, we could have a really high SVR. And so that's also common on our patients that before they went in, they've been hypertensive for years. This morning, they didn't take their beta blocker because they knew that they were having open heart surgery and they shouldn't have. And so they go to, have surgery and now they come out and as they're waking up, they're super anxious. They are just clamping down. All their hypertensive stuff is coming back. And now their blood pressure is through the roof. Their blood pressure is through the roof and their SVR is through the roof. As their SVR gets too high, you're going to see their cardiac output drop. I have tons of nurses that I work with that will come to me and say, like, I don't know what to do. My patient's cardiac output's super low. I walk in, their cardiac output's 1.9. Everything else looks normal, and there's one thing that's off, and it's almost always the SVR. And our monitors is down in the bottom right corner. And that SVR will be like 2400. And so that's the clue. That's the key. The heart needs to have not so much resistance, and then it will be able to increase the cardiac output, which means it'll increase the amount of blood going to the whole body. So we treat that SVR in different ways. If their blood pressure can tolerate it, we might use carding. We may use, a lot of times these patients are in pain when they're waking up and they're just kind of clamped down, hurting. So we may use morphine on those patients, just a little 2 milligrams of morphine to see if they can tolerate it, see if it relaxes everything. Those are some common things that we use. Also, we know our patients will experience vasoconstriction if they're hypothermic. So we may just look up and see like, oh, they're 95. And we put the bear hugger on them and get their temperature up, and that will also help decrease the SVR. If we see that our patient has a low SVR that's affecting cardiac output and their index is like not where we want it to be, their cardiac index is not where it should be, and their SVR is too low, we may have to use suppressors. So we're probably going to have that patient on a touch of epinephrine or a touch of Levophed, something like that, that will just increase the squeeze on those vessels. And so all those things are part of the big picture as we think about hemodynamics in a cardiac ICU patient, and how we can optimize those things so that our patient can have the best cardiac output and therefore perfuse their organs and have good outcomes. So continue to follow this series about hemodynamics, and we'll continue to talk all the things so that you can be a competent and confident bedside nurse.